Good afternoon, everyone. Thank you very much for joining us again today for another Ortho Illinois Workers' Compensation Power Lunch. We know you're juggling a lot, so we really appreciate you carving out time in your busy schedules to be here with us today. And without further delay, want to introduce Dr. Scott Trenhaile. Dr. Trenhaile, thank you very much.
Thank you, Bill. So today we're going to talk about managing full thickness rotator cuff tears, better, faster healing to get back to work. I'm a member of Ortho Illinois. I have a couple of disclosures here, and just a little bit about me. I'm fellowship trained orthopedic surgeon. I specialize primarily in shoulder, probably 90% shoulder, and a little bit of knee and elbow. I basically take care of shoulder injuries and problems anywhere between the ages of 9 and 90. It says here probably 9 and 100 on up. It includes complex reconstruction, revision reconstruction, shoulder, and some, like I said, some knee and elbow as well. I do a lot of educating actually on the shoulder topics specifically, and this is at the national and international level. And I still am active in doing some research as well, included as well as publishing papers and book chapters. I really enjoy innovation. I've got 9 fully executed patents and probably 30 abandoned patents that I just couldn't keep funding and pushing forward to try to get. And probably the biggest thing where this all started was the all arthroscopic biceps tenodesis platform, but there's been many other things since then. So very passionate about the shoulder. This is really where my interest is. Wanted to talk today about rotator cuffs because in the rotator cuff realm, this is a very devastating thing to happen at the workplace. It's a common thing that happens in the workplace, and it's important to define whether this is a single traumatic event, a repetitive micro trauma event. Is it associated with things like impingement? And we get into things like pain overhead and night pain, and trying to establish, are these acute or chronic symptoms? And certainly, of course, causation. There's lots of tests that you can do in the office, and we always do a physical exam. These are just a few listed here, but basically what we're trying to understand is, does the patient's story corroborate with the MRI, which corroborates with the physical exam? So there's things that we can do with that. The MRI, as we know, is very important because the shoulder is a very soft tissue dependent structure. And so oftentimes when patients have profound weakness, we like to get an MRI right away. You can see here with the yellow circles, an intact rotator cuff on the top and a torn rotator cuff on the bottom where the tendon is pulled off the bone. Sometimes if people have mild to no weakness, we try things, conservative measures like physical therapy, non-steroidal anti-inflammatory medications, and possibly even a cortisone injection. And oftentimes those people that don't have a tear can rebound very quickly and get back to work. But if that fails, then certainly an MRI is reasonable. It's important to note that not all rotator cuffs are equal. There are small tears, large tears. Here, the small tear with the purple line shows that the distance is probably a centimeter. And then a large tear, which this is probably 3 to 4 centimeters in size in terms of retraction. And then we always look at the atrophy. So the muscles around the shoulder girdle, the muscle is quality can really tell us a lot in terms of not only the success or not with regards to treatment and failure, but also the causation in terms of the timing of the injury. So here's a staging where we're looking at one of the worst cuffs on the left, which has a lot of fat and very little muscle. And on the far right, you see mostly muscle and no fat. And so when we look at fatty infiltration, the higher the fatty content, means typically the longer that tear's been there, and that correlates to higher re-tear rates and outcomes, and also, again, can help us with causation. So just a little plug, if there's an injury around the shoulder itself, an MRI sooner than later can let us know this is not related because this has been there for a long time, or this is a new injury, and not only will it help define causation, but it'll help treat the patient, and they'll get a better outcome if they get treatment sooner. This is just an article that I found interesting, published back in 2023, American Journal of Sports Medicine, rather. They did a systematic review of over 8,000 patients, and they looked at the role of delaying between the injury and the surgery in terms of outcomes of rotator cuff. And it's school of common sense here, but patients who had a delay of over or equal to a year resulted in higher re-tear rates after rotator cuff repair. So I think earlier intervention is better for the patient and the worker and the work environment. So indications for surgery, obviously full thickness cuff tears by MRI, partial thickness rotator cuff tears. You see this video in the upper right where this is a partial tear that we're debriding. This failed conservative measures like potentially a shot, medicine, exercises, etc. And what we know is that there's various studies that talk about this, but full thickness cuff tears typically don't get smaller, they get bigger. But when treated appropriately, we can usually get people back to MMI in as early as 12 weeks and sometimes as long as 24 weeks, depending on what's going on. These protocols were included in your handouts. They're available. I'm not going to go through this in depth, but there's a significant difference between a small cuff tear, repair, and return to work protocol versus a large. It's sort of broken down into phases, 0 to 10 days, 10 days to 4 weeks, 4 weeks to 8 weeks, 8 weeks to 12 weeks, 12 weeks to 16 weeks, and then beyond where you get into your MMI. But these are things that we try to mention and not only talk to the patients about, but document in the record so that we can kind of set expectations of, hey, you've got a rotator cuff, it needs to be fixed. And this is sort of what we're looking at in terms of your overall situation. So when we look at a large to massive cuff tear, this individual, you can tell on the left arm, he can raise it all the way up. On the right, he can't. This is called pseudoparalysis. And that's loss of containment because you've got probably anywhere between 3 to 4 tendons are torn off the bone. And so the patient can't contain the ball and socket, so they can't depress the humeral head so they can raise their arm up over their head. Bad situation. And so this is a protocol indicating a large cuff return to work protocol, which is everything's delayed at least 6 weeks or more just to increase time for healing and strengthening. We do talk about different modes of healing. I don't want to bore everyone with biology here, but there's a lot of talk about different types of implants. There's repairing the cuff, and then there's repairing the cuff with some type of augmentation. And definitely not all augmentations are the same. So there are, on the left, you see conduction. This is with a dermal graft. So that's a skin graft that's designed to go on top of a rotator cuff. And what happens with a dermal graft is the graft heals down to the rotator cuff that's been repaired. But in essence, what happens is there's a generalized biology response. So what happens is the dermal graft heals basically into scar, and it is always scar forever. And when that's tested biomechanically in an animal model, it only performs about half as strong as the native footprint if you didn't have a tear. Now on the right side, you see induction or a particular response, and these are bioinductive implants that create tissue to integrate into the native rotator cuff and the bone. And when that happens, it transfers the load beautifully, and the biomechanical output of that is much, much better. So we're going to talk about this in a second, but not all grafts are the same. You've got a dermal graft on the left with conduction and a bioinductive implant on the right. And there's several bioinductive implants on the market, just to talk about that agnostically, in that there's others to choose from, but they make the healing much different. This is an example of a bioinductive implant. It's non-structural, but you put this in, it's type 1 collagen, and you insert it. It's got less than 50 nanograms of DNA or protein, so there really is no rejection. It's just pharmaceutical grade collagen. It's highly porous, minimally cross-linked, and it's highly oriented. And that's what turns on the fibroblast to get the rotator cuff to heal itself and thicken it up. So when you've got people talking about, well, I'm going to put a graft over this, maybe ask, what are they using? Because there's different companies that do this, not just the one that you just saw on the screen. So, and this is just a quick technique of putting one of these in. And granted, this technology's been around. I've been doing this since 2014. I've published on this at least 4 times in the literature myself. And but it's, interestingly enough, it just received a 4 out of 4 star recommendation from the American Academy of Orthopedic Surgeons. That's a really big deal because bioinductive implants have been sort of studied and questioned for quite some time until just late in 2025 when they came out with a blanket study that said that, or blanket statement that is, the bioinductive implant is a very positive thing for rotator cuff repairs. And I can't think of a better time to use it than in the work comp environment. So there you go. That's one being put in. There's lots of studies. It's a crazy busy slide. Some of the articles I'm here on myself, but it's great for using on partial thickness cuff tears. In terms of outcomes, it's been shown to be very effective. And the early study, a lot of the early work, I was involved with a lot of this. We looked at things out of the rebuild registry and found that when you look at sling time, we could diminish the sling time on a partial thickness cuff tear from 42 days down to 10 days when we used the bioinductive implant. We could get people driving 13 days versus 21 days without it. Sedentary work, they could do sedentary work at 11 days versus 60 days. They could do heavy labor work at 38.8 days versus 60 days. And their narcotic use was off for the whole cohort by 19 days versus 35 days. So in the partials group, this is a really nice option for treating people as opposed to, say, cut into the cuff, make a big tear, and then fix it. Well, now you've got a full thickness cuff tear problem. On the full thickness side, again, really crazy busy slide. And again, I helped publish some of this data, but basically it's been shown to be very effective in helping to heal full thickness cuff tears. And so when we look at this bioinductive implant, re-tear rates are between 3.5 and 11% versus this article in 2022 by Valet. He looked at, I think it was 4,000 to 5,000 cuff repairs without augmentation, so just repairs only, using, instead of bioinductive augmentation, using the autograft biceps or fasciolata or allograft, that being dermis or fascia, and they had between a 21 and 27% re-tear rate. So not as good, and there's a whole bunch of reasons why that is I won't go into. In conclusion, I've always kind of thought, well, the bioinductive implant is safe, it's effective, great outcomes, you got a great big tear. This is what we need to do until we find something better. And so here's a great big tear. And we did a transosseous equivalent double row repair, which we've always thought biomechanically was gold standard. In this case, the patient had some tendon loss, so we put a bioinductive implant over the top. And that's great. That's state of the art. Well, maybe it isn't. And so this is kind of the second half of my talk on rotator cuff. When you look at rotator cuffs overall, we've sort of normalized failure. So, and what I mean by that is you can look at all kinds of articles that re-tear rates can be anywhere between 8 and 94%. There's a wide variability due to the construct mechanics and biology. And sometimes it's not surgeon skill, it's many other factors. And so we've kind of been using this transosseous equivalent double row repair, which I just showed you, as the gold standard for the biomechanical, the mechanical piece of the biomechanical equation. And so how have we normalized failure? Well, we talk about these high failure rates with patients, and we've sort of absorbed them into expectations. And what I mean by that is we look at somebody and say, well, you got a really bad tear. We're going to have you wear a sling for a really long time. We're going to delay your rehab. We're going to protect our vulnerable construct because we're worried it might tear out. And so we mitigate risk because we don't trust the security of our repair. And that's the delicate balance that we deal with all the time. We want to get patients moving quickly with early mobility. So, hey, we're going to get you out of your sling. We're going to get you into therapy. We're going to get you back to life. It's going to feel great and better. And we'll get you back doing activities that you not only like to do, but you need to do, versus the healing piece where, hey, we're going to put you in a sling. We got to hold off on therapy. You're going to have to cook for 6 weeks and just sit there. And then once the healing's good enough, then we can start to stress this and move it and then get you into therapy and start to think about getting rid of the sling. And most patients in today's world favor the healing conservative side, not the early mobility side. So the question is, what have we optimized and what we haven't? Again, we spent decades of focus on time zero fixation strength with various suturing techniques and less attention on load distribution and biologic compatibility. So strong at surgery, meaning at the day you fixed it, doesn't mean guaranteed durable healing. And so this is a classic slide that a lot of people refer to. This was Dr. Park in 2007. And you can see on the picture, the transosseous equivalent double row repair, TOE, is the B, is picture B, where the sutures are crisscrossed. And what they found biomechanically, and that there was a real advantage for medium to large tears biomechanically for the TOE on the right versus standard anchors on the left. And since 2007, that's been kind of our go-to, like if you can do a TOE, you should do this for your patients because it's really good. Well, we also learned that when you do a TOE, there's ways you can mess this up. And you can actually over-reduce the tendon. You can pass the sutures obliquely, which creates strangulation of the tissue. You can put the sutures too close, and then you can get some quick tissue necrosis. And you can get an actual failure or a type 2 failure where it ruptures medial to where the repair is, which is pretty devastating because then you don't have a lot of tendon left to work with. It's a big problem. So there's lots of articles that talk about how to do a TOE correctly so that you get it right and help the patient the most. Here's an article that talks about spacing out your sutures, doing multiple passes instead of pulling the sutures all through one hole or another. And yes, this actually helps biomechanical performance. But when we look at the biological factors, what else can we do to help patients? Well, probably the implants matter and the patient factors matter, like things like diabetes, smoking, systemic inflammatory processes, and even osteoporosis, believe it or not, is an issue. And I would even argue work comp patients are on this list. And I'll explain that in a little bit. But here's an article that looked at factors affecting arthroscopic rotator cuff healing. And they found that osteoporosis was an independent risk factor for arthroscopic rotator cuff repair. That was in 2011. In 2016, we've got an article here that shows if you're using implants that allow the bone marrow to come up from the bone into the rotator cuff above, that's a good thing. So they took patients with and without vented anchors that are in the bone, holding the cuff down to the bone, and they found that at 6 weeks, the vented anchors, the cuff healing was better, and the tissue was thicker. So the implants matter. And when we go back to this slide that I spent quite a bit of time with, you can see that bioinductive augmentation can help the healing by improving the biology of the healing process on the right. However, if you look closely here, 2-year outcomes, bioinductive augmentation, arthroscopic full thickness cuff repairs. My name is on this paper. I'm one of the authors. We had a 16% re-tear rate at 1 year, and that went up to 20.8% at 2 years using a double row. On some of these, the ones that we used a double row on, that number went down to 13%. But also what we found was that if bad things were going to happen, it usually happens early, meaning during the healing fixation process. And that was published in 2022. So is the TOE better? Yes. Is it better if we put a bioinductive implant on? Yes. Is it perfect? No. And so here's an article by Ruiz Iban. He's over in Spain. He's a colleague of mine I know pretty well. He did a level 1 study, completely randomized trial where patients either got the TOE or they got the TOE with the bioinductive implant. And there was a 3 times lower risk of re-tear rate with better integrity and no difference in complications. However, of that 8.3% re-tear rate, the ones that tore, they tore at the myotendinous junction, which is a type 2 failure, which is bad. So that there's still some bad things that can happen. So in the current state of biologics and biomechanics, augmentation, meaning the bioinductive implant, improves healing rates, probably better than dermal grafts, but doesn't eliminate failure. Single row constructs don't do as well as double row constructs, that being the transosseous equivalent double row repair. And what we found is that the transosseous equivalent, or the TOEs, they do better than the single rows, but they still can fail early if they're going to fail, and it can be catastrophic. So where does that leave us now? This is painful for a lot of folks, so I'll try to make this as brief as possible. When you take a TOE and you test it biomechanically in a lab where you pull on it, on the lower right, you see a TOE 183 newtons. That's where it fails. A TOE with knots fails at 260 newtons, and a healthy rotator cuff muscle, when it fires and pulls on your normal tendon without a tear, is at 302 newtons. That is why when you fix somebody, you have to put them in a sling to allow that TOE to heal, to come up to the level of 302 newtons, so that when your normal rotator cuff fires, it doesn't pull your construct apart. And you can see how the construct on these pictures, it's failing. Okay? And what's happening is you've got this load concentration on the sutures, which cheese wires its way through the tendon, creating gap formation and shear and tendon strangulation. All of this is happening before healing has ever had a chance to really get going. And we've seen this clinically as well. The group out of Cleveland Clinic, they put cannula markers into rotator cuff repairs, and then they MRI'd them after surgery. And basically what they proved with this study is all rotator cuffs, when they're attached onto the bone, they all stretch while they heal. So it's a race between healing and failing. And so you can end up with a failure and continuity kind of situation. And I'm going to show you a video of what that really looks like. So the key insight here is the bioinductive implants are probably great for partials. And I think we've pretty much solved that partial cuff problem. But on the full thickness side, biology can't rescue a mechanically disadvantaged construct. Failure patterns are predictable, not random. And improved healing requires improved load sharing. So I told you that biology can help improved healing, but maybe there's something we've missed. And so this is where we really go into the future. This is the futuristic part of this whole talk, the paradigm shift. What we need to do when we fix rotator cuffs is replicate the native tendon. No one would argue that. The textile industry has figured this out years ago. And so when you look at a common seatbelt, you see the seatbelt stitches going traversely across the fabric seams that are running this way, and the sutures are going this way perpendicularly. That seatbelt is extremely strong. So fixation stronger than rotator cuff pull, multiple points of fixation, a complete line of attachment across, broad area of attachment that matches anatomic tension and stiffness, stable construct that promotes healing and lets biology in, and is a low profile repair, potentially knotless if possible, so it doesn't rub. And that's the picture that you see down below on the rotator cuff. This is a new system called tendon seam. And I actually helped develop this, and it's pretty remarkable. Basically, it's a series of peak anchors that are 2 millimeters by 10 millimeters. So these are pretty tiny. They go through the tendon, into the bone. They toggle underneath the bone, and they flip. And then each one of these anchors is locked with a locking stitch, so it can't move. And why that's such a great thing is it really promotes load sharing amongst the whole construct rather than all this point tension with each suture. So this is what a tendon seam looks like when it's done. Kind of like a sewing machine. If you think of a sewing machine and in the textile business, you start and you go straight across. So you've got a medial seam of anchors that are strong, load sharing. There's a lateral zigzag on the outside part to replicate the TOE portion, which doesn't really bear that much load, but it helps the healing process of the whole footprint. And this construct flexes with the native muscle that's pulling, so it doesn't rip out. And there's a whole bunch of holes underneath because you've got 1, 2, 3, 4, 5, 6, 7. You got at least eight holes there that are leaking out bone marrow so that you get access to biology, and it's all knotless. Of course, we studied this. This is a biomechanical study done with cadavers in a lab using an MTS machine. And so what we did was we looked at the TOE versus tendon seam, and basically at 30 cycles with 180 newtons, the tendon seam didn't even move a third of a millimeter, and the TOE moved almost 5 millimeters. So that's not good. And then we tested it out even farther, what a TOE can't do, and the results are pretty amazing. What these results showed us that tendon seam can probably exceed healthy rotator cuff muscle, that 302 number, and really starts us to make us scratch our head to say, maybe we don't need to wear a sling after rotator cuff surgery. Kind of a big deal. So again, TOE, 183 newtons, TOE with knots, 260 newtons, normal healthy muscle, 302 newtons, tendon seam is at 600 newtons. So almost double. It's over double what the TOE can do, and it's double of what a normal muscle can do. And so this is a video where you've got TOE on the right and you've got tendon seam on the left. So look at the edge of the tendon. You see the little blue lines there, and you can see how things are moving. The one on the left is 180 newtons of pull. The one on the right was only 10. So now they're both at 180 newtons, and you can see the displacement with the TOE. And at the end of 30 cycles, there's a lot of stretch on the right. Now watch when we do 500 cycles at 302. So this is somebody who got a shoulder surgery and didn't wear their sling. Okay? How many people, now watch this, when we let off, look at how lax those sutures are on the TOE on the right. That is a failure in continuity. And that is potentially a work comp patient who had a bunch of time off after shoulder surgery, and they were supposed to be resting, and they went out and cleaned their garage and got in trouble, or were moving their motorcycle around, or did something they shouldn't have been doing. So they're an at-risk patient. And so Dr. Harris down in Dallas, he was really the core designer of this system. It's amazing. And he went after the hardest patients you can go after, these massive cuff tears, large to massive, 68%, followed them up with MRIs around 13 weeks out and had an independent radiologist read them. He had 11% re-tear rate in a group that he expected at least 30 to 40% re-tear. These are your scariest repairs. So that's encouraging for the high-risk population. Pat Connor, he's also a core designer of this tendon seam technology. 130 patients, 49% of these were large to massives. He had a 4.6% recurrent rate, a 2.3% reoperation rate, medium sling time 2.5 weeks. So he's letting people kind of progress to rehab and getting them out of their sling early. Based on this, this is very, very early data, and there's a new trial, a big trial going on right now with MRIs at 1 year and full thickness cuff tears, and way more to come. I'm not really allowed to give you any results of this yet, but it's going on and happening as we speak. The instrument looks like this, not that anyone cares, but it's pretty neat device. The way it goes in, you punch a hole, you deliver an anchor, so you push it into the bone, you tension, which flips the anchor under the bone, under the cortical bone, and then you lock it. And then you move on. So punch, deliver, tension, lock. And these are a whole bunch of patients from Dr. Watling, Connor, and Weissman, and LeBay. The large tear, large revision tear, medium tear, massive tear, high-grade partial tear, and large tear. And these are people at 6 weeks, between 2.5 and 6 weeks out. We've got therapists also giving lots of testimonials from Houston and Charlotte. They notice a difference because the patients don't hurt as much, and they're doing so much better. So this is a pretty neat thing that's coming online and something to watch out for in the future. I wanted to share a case that I did. This is a 4-week relook. I did a 56-year-old male who was a motorcycle rider, big advocate of that. And he had a 4-year history of right shoulder pain. He was a diabetic. He had gout. He had GERD and had multiple bariatric surgeries. He'd lost like 150 pounds. So he was basically malnourished in a lot of ways. When people lose a lot of weight quickly, there's a lot of metabolic issues with that. He tried some conservative stuff and failed and was referred to me. I fixed his rotator cuff using the tendon seam. He felt a big pop in his arm, and lo and behold, the cuff was intact, but the biceps had dehisced. So that MRI on the right shows the first pre-op tear, and this is the tear before I fixed it. So he wanted his biceps fixed, so we went back and fixed his biceps, but we also took a look at the rotator cuff. So this is the index procedure where I'm punching the holes, delivering the anchors, and this is all one suture, so it's load sharing. It'd be like if you're in a group with your friends and you're all holding hands together, you're much stronger than if just by yourself. So we fixed the rotator cuff. There's the initial repair. He ruptured his biceps, which you can't see in this view. It was used with different fixation. This is what it looked like at 4 weeks. Rotator cuff was healed beautifully. Lots of biology going on here. Yeah, it's red. It's inflamed. It's healing. But when I saw this, this is what really got me going. I started to think about, wow, maybe patients I could believe the data that said, hey, we could get rid of the sling earlier in certain tears, in certain instances, and we can get people moving sooner, which overall is better for their well-being and recovery. So we're kind of winding this down. Do you have any other keywords?
No, we just had the 2.
Okay, that's it. Can we say them again?
We can. So keyword number 1 was rotator cuff repair. So rotator cuff repair was keyword number 1. Keyword number 2, improved healing.
Improved healing.
Yes.
Okay. So I think of this as a classic bell curve in terms of how I would use this technology. I wouldn't use it on partials, I don't think. Some people are, but I think in general, the bioinductive implants are really on the far left in your classic bell-shaped curve are doing that. On the far right, you've got patients who've got really bad bone quality, bad tendon loss, and you're fixing whatever you can to bad bone and hoping for the best. So that's maybe a single row, maybe it's a TOE. You're adding Regeniten and hoping that that'll help. But all these others in the middle could be treated with tendon seam, I think, plus or minus a Regeniten, a bioinductive implant over the top. So buckle up. Here's the final slide here. If you get a rotator cuff that's operative, it's partial thickness, maybe use a bioinductive implant, no sling, start PT right away. If you've got a full thickness cuff tear, you check the bone quality. If it's really horrible, like it's mush, then you check the tendon quality and excursion. That is bad, then they get a single row with bioinductive implant, and you hold the sling for 6 weeks. You put them in a sling for 6 weeks, and you hold PT for 6 weeks. If the tendon quality is not bad, maybe you do a TOE, and then you do a bioinductive implant over the top, but you end up doing the same rehab, going slow. If the bone quality is good, which most people's is good, then you do a small cuff repair, you do the tendon seam, and you get them moving right away with no sling. 2 weeks in the sling, potentially. Medium cuff tear, check their biologic factors. If they don't have any, same course of action. If they do, then maybe you add the bioinductive implant over the top. And classically, we'd put them in a sling for 6 weeks, but we'd start therapy right away. Large, same story. Massive, we'd do the bioinductive implant over the top of the tendon seam, and we'd hold everything classically. But the longer I go with this new system, I find myself edging towards get out of the sling early and start PT right away. It's a case-by-case basis at this point. I know that's a crazy, crazy slide, but it it's you're going to get a different story based on different characteristics of what's going on with your work comp patient and their rotator cuff tear, their size of cuff tear, their chronicity of their cuff tear, their bone quality, their tendon excursion, their biologic factors, et cetera, and on and on. So with that, I'm going to stop. And I really appreciate your attention on this. If we have any questions, we can get into a few of those.
If you do have any questions regarding workers' compensation referrals or just to learn more about our Fast Track program for injured workers, please visit orthoillinois.com and click on Employers. For Algonquin, Elgin, McHenry, and the greater Chicagoland area, you can call Paul Strandquist at 815-847-7088. For Rockford, North Central Illinois, and Southern Wisconsin, you can call me, Bill Collar, 815-847-7044. We've got a bunch of great questions. Nicole asked this one a little bit earlier before we talked about the tendon seam, but I think if I recognize Nicole's name, I think Nicole's a case manager. So from a case manager standpoint, if you feel a patient would be a good candidate for a biopatch, but the treating physician has not recommended that, what do you think as a physician would be your best approach from the nurse case manager to the physician to suggest maybe looking at alternative treatments?
So if I understand this right, the surgeon who's treating the patient didn't recommend a bioinductive implant, and the nurse is questioning maybe they should have one.
Yeah.
Here's what I would do. I would, as a nurse case manager, I would say maybe just, it's not uncommon to have nurse case managers ask questions that are very on topic, and it's uncomfortable for the surgeon sometimes because maybe they didn't know all the whole story, and the nurse case manager knows a lot of the story. But maybe a nice way to bring it up is what you're maybe suggesting is, doctor, are there any other biologic factors that you would worry about for healing, or anything you could do more for re-tear rates or to get this patient back faster? Is there anything we could explore, or is anything you're worried about with the host being the patient? Like, are they diabetic? Are they, on a bunch of meds for things that are really needed for systemic inflammatory processes, but they don't really bode well with rotator cuff healing?
You gave a lot of different options for the rotator cuff repair. Talk a little bit, if you can, about the contraindications for each, how they differ. So between dermal implant, the bioinductive implant, and then a tendon seam, are there different contraindications for each?
Well, so in my hands, I've been through every graft there is. Starting back in the beginning of my training, we were using SISM grafts, which is a small intestine of a pig.
Okay.
We used horse grafts. We used dermal grafts. We used rotator cuff graft from cadaver. We used, I've been exposed to every one of these grafts, and for me, I don't use dermal grafts anymore. It'd have to be a really unique, rare instance where I would recommend a dermal graft. But in terms of a contraindication for tendon seam can't work everywhere. Like I said, if you have really soft bone, it doesn't work. Those little anchors will pull right out. So that's a game time decision when you're in the OR with that. And the bioinductive implant, that's a situation where one of the issues we run into with work comp patients is we're always trying to advocate for the patient, but the biggest thing is we're trying to get their surgery approved. And with certain payers and things, there's more pushback than others, and sometimes if you recommend that, they'll deny the whole thing and send them off for an IME, and that delays everything. Which, as I presented here, the longer you take to get a cuff fixed, potentially the higher the re-tear rate and the worse they do. So you kind of have to pick your battles sometimes.
Yeah. We've all seen that in workers' comp, that a certain carrier may require that you fail physical therapy before the MRI or whatever. How do you balance medical necessity with the insurance authorization and review requirements, what are some of the criteria that you can give nurse case managers to maybe help that approval along with the carrier?
Well, again, no, having the understanding that time does matter, and having the understanding that the tendon muscle unit decays over time, and you can see that on an MRI. With the muscle will start to get smaller, it gets replaced by fat or fatty infiltration. We just know those. I mean, those are instances where advocating for the patient to get surgery sooner is better. Sometimes doing if it's the nomenclature and the way radiologists sometimes word things on the MRI report make it hard to get the surgery approved because they'll say near full thickness, partial, near, complete tear. What does that mean? Right? Like it's very contradictory. And sometimes you just send them off to PT for a few weeks to say you did it and knowing full well that it's not going to work. But it's probably the fastest way to get them through the system to help advocate for the patient. And frankly, to get them fixed so they can go back to work. And get them back in the workforce because everybody wants that. At least most people should. I mean, if their intentions are correct.
The goal is to get them at MMI released to full duty.
Get them back.
Right.
That's the goal.
Leanne has the $64,000 question, which is, how do you determine good bone quality?
That's pretty. So that's a great. I mean, so wow. Clinically, we check it in the OR. When we do, we'll take the shaver and we'll remove the soft tissue particles and bits that are still hooked onto the greater tuberosity. And that tells us how hard the bone is, just clinically when we touch it and feel it. I'm involved with a project right now. I'm going off on a soapbox here, but this is so cool. There's a whole field called radiomics. And radiomics is the study of basic medical imaging that allows you to quantify that imaging and make it mineable data using machine learning and artificial intelligence. Now, what that means is no special tests, no crazy bone densitometries on people, but in the near future, you're going to see radiomics tools. In fact, I'm involved with a different project where we're creating a tool where we can feed in regular studies that are already done, and we can come back with scores on how healthy is the muscle. So instead of getting an answer like 3 centimeter full thickness cuff tear with mild retraction on the MRI report, you would get a report that would say the muscle quality texture is grade whatever. The tear edge tendon has a characteristic of X, Y, and Z with a score of 58 out of 100. The bone quality is dense to the point of blah, 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 blah. So each element of the repair that you're going after, you'll know how healthy the tendon is, how healthy the muscle is, how firm the bone is. And this is the field of radiomics. And no one's really heard that word, but if you look it up, that's how you tell how hard the bone is for real, using mineable data and regular imaging that we already have. We just have to use it in a way where we let machine learning take over and help us out. It's pretty fascinating. Yeah, it's really bleeding edge stuff.
Current state, the only way to know for sure is to open that area up and test and look. But you are looking for ways.
We want to know preoperatively so that we can tell the nurse case managers and the adjusters and the and the patient, like, look, your bone quality is really poor. Your radiomic score is X, Y, and Z. Your muscle's not very good. This is what your outcome will be. Like, we'll be able to tell who's going to be able to go back to work or not. I mean, we kind of know now. Mm-hmm. I've been in practice for 25 years, but yeah, we'll have discrete data that will send out a report that it will basically tell you, and I think that information will help us get people approved for certain things. and maybe not approved for things that don't need to be done. Like, there's no point in fixing this scuff. It's never going to heal. It's never going to work. There's too much retraction, too much fatty atrophy, too much of this, too much that. The outcome score will be X, Y, and Z. Therefore, no surgery.
Right.
Which will save a lot of pain and angst and dollars and all kinds of stuff.
And
it's exciting stuff.
Yeah, heaven forbid there is some kind of outcome unexpected. And like you said, if you get a tear, it's more medial, that's a bigger problem.
Yep.
When your treatment algorithm slide, well, busy, but I think it did a really good job of, for the nurse case managers who are trying to understand how come patient Smith was back in 12 weeks and patient Jones is taking
forever.
30.
Yeah. Right.
Can you talk a little bit more about some specific comorbidities or that we know the big ones: diabetes, smoking, osteoporosis. Those come into play even more in a work comp system.
One of the things that was not on the slide, because the slide was so crazy I couldn't put more on there, but one of the things that is, we talk about the tendon excursion, the tendon health. One of the toughest, when you see a smaller tear that ruptures and it gradually gets bigger versus a really big traumatic tear that tears off and kind of curls back from where it's supposed to be and then doesn't get fixed for a year, that curled back state, when you try to unroll it back out like a roll of carpet and put it back down, it doesn't want to come. Mm-hmm. So those are different animals. They behave differently. There's cuff tear pattern, there's cuff tear retraction, there's excursion, there's all these different mobilities. Like, there's all kinds of releases and things we can do to try to get the tendon to come back home. But sometimes it's just, there's a lot of tendon loss, and it's, when you pull it back over and hook it on, it's like putting a queen size sheet on a king size bed. It's tight.
Yeah.
It's tight, and it may hold or it may not hold.
As much as we want the same outcome every single time, patient X and patient Y are different. Never the same.
Yeah, there's different, but I think in looking into the future of this, I really do believe like we'll be able to have way better concrete information that could help prepare everyone for what they're in for, especially for some, like I've been at this for over 2 decades and I've learned a lot along the way. That shoulder IQ or surgical IQ for rotator cuffs will help younger surgeons make better decisions early on, even though they know what they're doing, they know their indications, but having that crystal ball knowledge of looking forward, I think will help.
Is part of that treatment algorithm, 2 keywords in workers' compensation are always work conditioning and functional capacity evaluations. How do you determine when or if either of those is indicated in a patient?
Obviously, we all know if a patient's got a really heavy job and it's in a tough area where it's fairly constant, they're probably going to need some work conditioning. Having been through cuff surgery myself, you get deconditioned. You do. It's like, it's just, you can't perform. You lose a lot. You'll get it back, but you need to get built up, and just doing regular PT in an isolated manner isn't going to do it for you. The FCE concept is really tricky because we try not to order FCEs. We don't want to give people permanent restrictions. We do want to get them back to work. And it's an occasional reality of things when we have to use it. And sometimes the FCE will actually help us understand if more therapy and whatnot will be beneficial. And sometimes you get surprised when the clinical situation is very complex. There's a lot going on with the patient other than just their shoulder. So, but again, we try to get people back without FCs. I think that's ideally that would be the best way to do it.
Dr. Trenhaile, thank you so much for your time. As I know you've got a busy schedule and really appreciate your time. We've had a great call, so we've got a bunch of people on here, I'm sure. If anybody has any other questions, feel free to email me and I can forward those on to Dr. Trenhaile and get those answered for you. We will give you 4 minutes extra of your day back. We're just a smidge early, but that's okay. Thank you again, everybody, for attending today. Last time, if you do have questions, problems, concerns with getting the survey done, anything like that, just email me, billc@orthoillinois.com. I hope everyone has a great day.